Hi, happy whatever day. Today's Thursday. I was like, what's today? Hi, everybody. Hi. Happy Thursday. Dr. Murray, we usually just give people like a couple minutes to like kind of log in. Happy Thursday, everyone. I'm super excited for tonight's interview. If you are hopping on, if you could just tell us hello and tell us where you're tuning in from or how'd you hear about it, because I know that this was advertised on a couple different platforms. So if you just want to tune in, tell us where you're tuning in from. Happy Thursday. Happy Thursday. We are really, really excited. This is actually our first Facebook Live of the season. We usually do Facebook Lives in the spring for Women's History Month. We have a series called Her Story, where we typically interview survivors of trauma. But I thought it was super powerful after I heard your presentation that we had you on our platform. So really excited. Hi, everybody. Happy Thursday. Happy Thursday. So, welcome. For those of you who do not know, my name is Christine Joy. I am the founder and executive director of Purple House Project PA. We're a local nonprofit organization with a mission to strengthen, empower, and transition women impacted by intimate partner violence. Each year, this is our seventh time, we've hosted our annual awareness walk / resource fair called My Purple Path. And each year we pick a subgroup of folks impacted by intimate partner violence. So this year, our topic is My Purple Path Needs You to Believe, and we're focusing on pediatric exposure to intimate partner violence. This topic came about from one of our former board members, Yolanda Jennings, at our event last year, where she got the chance to speak with Michelle Austin, who was actually one of our guest speakers for Purple Path this year, about childhood trauma. And Yolanda was like, Christine, I think next year's topic should be pediatric exposure to intimate partner violence. So this was last October. We thought about this theme. And in August, I had the privilege of hearing you speak at a conference about pediatric exposure, and just wanted to invite you on our platform. So here we are today. I'm super excited to welcome Dr. Ashley Murray to the stage. Dr. Ashley Murray is a professor, she is an attending, and she is an overall amazing advocate for folks impacted by intimate partner violence and all kinds of social health issues in the city of Philadelphia. So I'd like to give Dr. Murray the opportunity to introduce herself and share some information with us about who you are.
Thanks, Christine. That was a lovely introduction. Really excited to be here to speak with you. This is my first Facebook Live ever, so I'm excited. So I'm a physician at CHOP. I'm actually an emergency medicine physician. I've been at CHOP now for 15 years, but I'm here, my capacity. I've been running our domestic violence program called Stop IPV for the last 10 years. And I find the prevention of intimate partner violence an important thing that pediatricians in the healthcare setting should do and we should be good at. I'm a mom of 4 girls, so that is also really important to me to do this type of work. So I'm really excited to be here. Thank you, Christine. And call me Ashley, please.
Okay, yes, I'm Ashley. I haven't met an Ashley that I don't love. My little sister's name is Ashley. Best friend's name is Ashley. Favorite boss name is Ashley. I love Ashley. So let's just get right in. Can you define what pediatric exposure is? It's interesting because when we were coming up with the topic, I was just saying children affected by intimate partner violence. And then I heard that term and I was like, oh, this is like the medical professional term. So can you like unpack it, like tell us what it means medically, and then like give us the basic terms?
Sure. Yeah. So I think in working in the healthcare space, we encounter sort of 3 different situations in caring for families impacted by intimate partner violence, or I'll just call IPV. We care for the caregiver themselves that may have experienced IPV. We care for the child that has been exposed or maybe witnessed IPV, and I'll talk about the difference between the two. And then we also care for patients themselves that are survivors of teen dating violence or IPV as well. What goes along with this at the same time is also the co-occurrence of child abuse. And so that is something that we see often in these type of situations. And so when we see a caregiver that has experienced IPV, it's really important for us to think about what that exposure witness can look like to the child. And so there are sort of three main buckets we think about. And again, there's lots of continuums on the way this presents, but the first and foremost is the child themselves being abused, physically, sexually, or is the child also experiencing neglect? And we see that in about 40 to 60% of cases of caregiver IPV. And so that's really a big part of our job as pediatricians, ER doctors, to recognize when child abuse is happening, and reporting that and making sure the child is safe. Now, there's also what's called witness or exposure, and that's a little bit different than child abuse. Witness is when a child directly sees or hears the abuse, whether that is sexual or physical or arguing. So they're direct witness with their eyes. And that in some states is reportable. In other states, Pennsylvania, New Jersey, that is not reportable, which can be sometimes hard as a clinician to hear a child has seen or heard something. The third is exposure. And what I mean by exposure in children is really universal across every child that has a caregiver themselves that is a victim of IPV. And what I mean by that is if a parent or caregiver is experiencing trauma or violence themselves, that's going to impact the way they care for their child. They're parenting their child, right? If you can't show up 100% full authenticity of yourself, it's hard to be that parent that you really want to be. And so that's often what we call exposure. And exposure in pediatrics is not reportable in Pennsylvania or New Jersey unless there is high lethality. And I share one story about this. A few years ago, I cared for a child who had heard her mother being sexually abused for years through the walls. And she at one point became very depressed and wanted to harm herself. And in those types of situations, we would report because that's a high lethality situation where that child was at immediate harm to themselves. So that's sort of the overall definitions, Christine, that we think about when we care for families that are experiencing IPV.
Thank you for sharing that. And I think it's important to know. And when we were in the training, I was like, it's so many ins and outs and nuances and like what's reportable and what's not reportable. And I think I was talking to one of my really good friends after the presentation that I think that you all did a really good job at bridging the gap between reporting and domestic violence, because I know that sometimes like child welfare and domestic violence, it can sometimes be difficult to like commingle because we want to keep, we want to keep the children safe, but we also want to keep mom safe as well. And so I think in your presentation and even right now, just explaining what's reportable, what's not reportable, and the importance of intervention, no matter if something is reportable or not reportable. The reality of it is that oftentimes folks need services as well in addition. So thank you so much for sharing that.
And I was going to just add on that in situations where it may not be reportable by law, as physicians, we have to stop and think before we report because of the potential harm of reporting to the victim themselves, right? So that could actually cause more harm in those situations. And so it's just being very thoughtful about that and really being clear if you need to report to the family why you're reporting and creating a safety plan at the same time. So that way they are safe if Child Protective Services has to get involved.
Thank you for that. And the question we had too is, what can we as a community do, individuals and communities do, if they know that like children have been exposed to IPV in the home? What are some ways that we as a community could help?
Well, that I think you could unpack for hours. I mean, I think I can think about my own personal stories and situations I've seen with friends or family. Obviously, my big focus of my work is improving the healthcare system's response. I think it comes down to how close or like how well your friends are familiar with, if this is your coworker
Like if it
or
was
something.
your niece or something, like if it was your niece or your nephew or your cousin, because we have a lot of people who
Yeah.
like are survivors of IPV, and unfortunately they see it happen again in their family systems, and now they want to interrupt it and like see like how can I support that? That makes sense.
Yeah, no, that does make sense. And that's really a really tough question. And it's really need to be healing centered. And I've worked with several friends actually who've had friends and they want to intervene and they want to they don't understand why they're still with them, and they want to know what to do. And oftentimes what I teach and what I tell family members is, um, start with coming from a sense of empowerment. Like, and what that means is like, I really care about you. I'm your sister, or I'm your relative. You mean a lot to me. You're such a great mom. But I've noticed some things, or I have some concerns. What do you think about that? Trying to get a sense from them where they're at in dealing with whatever's going on in their life. Many victims aren't aware they're experiencing abuse, right? That may be so familiar to them growing up. Like you were saying, if they've experienced violence as a child, they may not be aware that that's abuse. So getting a sense of where they're at. I always say or teach, start from a place in compassion and empathy and healing centered. Not that you're going to fix the problem or solve the problem, but just being a listening ear. Sometimes people just want to hear that you notice and you care about them. Letting them speak, not pressuring them to share more than they feel comfortable with. And then if you feel comfortable sharing resources, if you're familiar with what Purple Heart does or any of the other domestic violence agencies, sharing like, oh, just want you to let you know there's some resources that exist, or I'm always here. One thing I do talk about is safety planning. I can be a safe person for you. If you ever need safe, we could create a safety word that you can send me. Really being there for them if what they need, not what you need, right? You have opinions of what they should or should not be doing. And they're already in a situation of power and control. They're already being controlled. And the last thing a family member or friend wants is to feel control from you. And so it's how do you put the control back in their court, but being there for them and supporting them when they feel safe to need you. So that's one big way. We do that in medicine. I think that exists even outside of medicine.
Are there like certain warning signs or red flags that you see when you see patients, without them even telling you that like they're impacted by intimate partner violence in the home? Like, are there certain warning signs or manifestations that you see?
Absolutely. I would say, I can break this down into whether a child is being exposed or a child is the victim themselves. So I'll start with the exposure piece. And so when I see children that present with signs of child abuse, I always ask about abuse to the parent as well. Other things can be more subtle, like what we call somatic complaints. So if we see kids come in with a lot of anxiety or depression, suicide attempt, if we see kids come in with a lot of abdominal pain or headaches or stress, and we can't really figure out what's going on. If we see children that have missed a lot of doctor's appointments, or they're behind on their vaccines or routine care, we think about it. We want to know what's going on in the home, how we can support the family. If we see two parents at a visit and one is dominating or controlling the conversation, we think about it. If we see adolescents in particular themselves who are experiencing depression or anxiety, or if adolescents have high risky sexual behaviors, early pregnancy, frequent STDs or sexually transmitted infections, those can all be medical warning signs or red flags that we need to think about it.
Okay.
I'll tell you a quick story. I think that's a pretty powerful story. This was several years back. We care for a lot of children in our emergency department who have mental health complaints. And I cared for an 8-year-old who came in with his mother, and the mom had got a report from the school that he was having behavioral concerns at school. They needed to bring him in. This little boy was the cutest thing. You would never imagine he was having problems at school. And he was playing on his iPad, and I started talking to the mom, and I had shared with her this screening tool we use in medicine that kind of has some questions about domestic violence in a way that's really safe for her, so she doesn't have to talk about it in front of the kid. But I wanted her to know, like, these are some things I'm worried about. Let me know what you think. And she lifted her head and said, not anymore. He's been in jail for 4 years. And I said, okay, all right. And the little boy looks up and says, oh yeah, my daddy used to chase my mommy around with a gun. And this kid was 8. And so if the dad has been in jail for 4 years, you can think about he was 4 the last time he was exposed. And that's a lasting impact. And I think that's really important for us as pediatricians and healthcare providers, that exposure can last a lifetime. And those behaviors we have to think about as sometimes being the result of early exposure to violence or trauma.
Yeah. I know you mostly work in pediatrics. But what does the research, and I'm sure you know this too, like what does the research say about like medical conditions? Like, so let's say, for instance, if children are impacted by trauma at a very young age, I'm thinking children with like high ACE scores.
Yep.
How does that impact like their physical health as adults? Is there a
Yeah.
correlation?
There absolutely is a correlation. So, just for anyone who may not be familiar with Christina's calling, ACEs are adverse childhood experiences. And there is the research really comes from more than 30 to 40 years old, but found that early exposure in utero, but also early childhood, um, redevelops the brain. So, the brain doesn't develop the way it's supposed to. And that's because of exposure to high levels of cortisol. So, if a mother is being exposed to abuse in the womb or the child has high levels of stress early in life, it actually reforms the brain. The brain doesn't develop in the way that it normally does. And that can
Mm,
lead to significant long term health, poor health outcomes from mental health, depression, anxiety, suicidality, physical health, chronic diseases, high blood pressure, heart disease, cancer, early death, high risk taking behaviors, which can lead to poor health outcomes, and also poorly controlled chronic disease. So, if someone has a chronic disease later in life, that can also be linked. And so, we know ACEs, the more ACEs that you're exposed to, the higher rates of poor health outcomes. But one of probably the most traumatic ACEs is actually child abuse, and that the co occurrence with that with domestic violence is what we really want to intervene on early in life with children.
mm. What are some of the interventions that CHOP like puts in place?
Yeah. So when I think about public health interventions, we think about primary prevention. So primary prevention is really sort of upstream. What can we do to prevent any sort of violence to begin with? The program that I partner with Lutheran Settlement House that is primary prevention is something called STAR, and that stands for Students Talking About Healthy Relationships or Relationships. And what's great about STAR is it is a in classroom program at the Philadelphia Public High Schools where we teach healthy relationship training within the schools. And what's really cool about that is it actually, the teens themselves are the ones that are co teaching the lessons. So
That's awesome.
LSH, Lutheran Settlement, offers a 6-week leadership training in the program in the summer, which I'm so lucky to be a part of. And the training program prepares the teens then to take on the training and become what do we call teen ambassadors. And then they are the experts in the schools to teach and share information to help primary prevention. We also have secondary prevention. So that is after the exposure happens. So let's say a child themselves are exposed to IPV in the caregiver. We know that um, child exposure, so either as a victim or a perpetrator, increases the risk of that child later in life being a
Mm-hmm.
victim themselves. And so we see this in the literature play out. And so we really want to intervene early in those children's lives after they've
Mm-hmm.
been exposed from their caregiver, so that they themselves later in life do not become a victim themselves. And so that's more secondary prevention. And that is really where our partnership with Lutheran Settlement and Laurel House come into play. Not only can we get support for the caregiver, but also the child. There's child counseling, child therapy. There are support groups that children can get involved in early in life so that they can break that cycle. And then the last is tertiary prevention, and that is really sort of downstream. That's where families and parents receive support through domestic violence agencies. And again, as a pediatric healthcare institution, we recognize we're not the experts when it comes to supporting the parents long term, but we recognize the community is, and that's a big piece of our program at CHOP is connecting caregivers to the community to support them in their healing journey.
Awesome. Thank you. As you were talking, I was just like, I feel like connection and resources are is our intervention, for the families as well. Because I think like lack of like food resources, adequate clothing, menstrual products, diapers, that's also,
Yeah,
something that like once people get connected to necessary services. So thank you so much for
absolutely.
breaking that down. We really, really appreciate it. Erica, do we have
You're
any
welcome.
questions in the comments? Any
We do
questions?
not have any questions in the comments, but we do have some comments about how powerful what you're saying is, and that people are really loving everything you had to say, Dr. Ashley. So that seems about it. No one has really any questions.
All right. Well, now's the time. So if you have any questions for Dr. Murray, oh, I see something. If you have any questions for Dr. Murray, you want to read this? Erica, I see someone just put something.
I shall read it. So it doesn't have a name attached to it, but the comment says, "My sister was murdered by her fiance. She had two small children. They've had a lot of mental health issues. My cousin was also killed by the father of her children, and she had three children by that person. Purple House Project helped my family member." And this is from Yolanda.
Oh yeah, she's our board member. She's the reason why we did the pediatric exposure to intimate partner violence. And although we could never take the pain that that family felt away, we was like, okay, what are some immediate needs that we can
Yeah.
provide for the family? Because the last thing you want to think about as you're processing domestic violence is how we're gonna eat, how we're gonna wash our clothes, and things like that.
Yeah.
Thank you so much, Yolanda, for sharing.
Yeah, thank you, Yolanda, for sharing. That's very. I'm sorry your family has experienced that and very powerful, but unfortunately, it is real and it is common, um, and it's really important for us, in healthcare. Like a lot, moms. I'm going to be very. I know I'll be a little biased here, but moms often seek more care for their children than themselves, and so after we have children, we get our 6 week postpartum visit, and that's it, and we don't always know what moms are experiencing, but we see children at 1 week, 2 weeks, 1 month,
Yeah.
2 months, four, right? We see children multiple times in healthcare because um, parents want their children to be okay and they care about their kids. And so they often put their kids first and they can be experiencing violence or abuse. And so this has, really been a career mission for me of how do we improve what we do at CHOP, but healthcare systems to recognize parents that are experiencing abuse, helping them to prevent things like Yolanda you've experienced. And it can be really sad and devastating. And if we can intervene, and I've seen some beautiful stories of this work as pediatricians have made connections with families and gotten the help that they've needed. But it's definitely a job that all of us need to do together in all of our different places where we work. So thank you for sharing.
Yeah.
We
I
do
think it's
have,
like a fine.
oops, sorry.
I was gonna say,
Go
I
ahead,
think it's like
Christine.
fine.
Sorry.
I think it's like a fine line too. People get really worried because they're worried that like, okay, if I finally go to the doctors and they recognize it, are they going to weaponize my abuse? And so I appreciate that you like talk about the importance of like sharing and connection to resources. And I'm a licensed social worker, and I remember the first time I had to make a report for someone, and I was like super transparent because that's what we're told, like to tell the family, like just so it's like no surprise, like, hey, I have to make a child line call and this is the reason why. And our hope is that more services are going to be put in place so that you no longer
Mhm.
have this X, Y, and Z. And so I think that like as providers, if we continue to be transparent and also like lean into like resources, but unfortunately that's not always how it goes. But the hope is that like,
Yeah.
you know, more services are put in place.
And that's what we learn from survivors, particularly within healthcare, is they want someone that's going to listen. They
Hmm.
want someone that's not going to judge them, and they don't want someone to be a superhero. And what do I mean by
Yeah.
that? As a physician, we and social worker and nurse or whatever we work in medical, we go into medicine to help people and we want what's best for people. But sometimes we don't know what's best for people and they know what's best for themselves. And I always say, up the survivor is seeing you. They've protected themselves and kept themselves alive, and they know how to do that, and we need to trust them. And because I think a
Yeah.
lot of times we want them to leave, or we want them to, why are you still with that person, or how are you putting your children in harm's way? But recognizing we don't understand the full picture, like you said, Christine, what else is happening, what are the resources that exist, and what do they need in the moment to get them the help they need. And that looks different for different people. And it's really important as clinicians that we take that time, take a pause, sit down, slow down, being transparent and working with them through what they think is best for themselves and help guiding them.
Yeah. I tell everyone that, the statistics show that the most fatal time is when someone decides to leave, when someone is able to leave. And so like it's important that like you said several times throughout this call, safety planning, seeing what the client wants to have them like lead the conversation. Erica, I think you were about to interject. Was there some more comments?
Yeah, so there's a couple more comments. Let's see. Melissa wants to know, how do students sign up to be student ambassadors?
Yes. So Melissa, Lutheran Settlement House puts out a call in the spring every year on their Facebook group, on their social media pages, and it's just for schools within Philadelphia. So since that's where they're situated, but Lutheran Settlement House does put that call out every spring for teens to sign up, and they get paid to do the program as well. So that is something that is available to the community.
I know Melissa personally, and I know she lives out of Philadelphia County. But do you
Yeah.
know in different if different counties like offer something similar, or they should probably model that if they don't?
I don't know what county. Yeah, so Montgomery County works with Laurel House. I know they work with their teens. I don't know to the extent of their involvement. I live in Camden County, so there are programs in Camden County. I'm familiar with all the other counties. I apologize, Melissa.
We can look into it though. We can look into it. I
Yeah.
know, like you said,
Mhm.
yeah, for
A
sure.
lot
And
of programs work with schools, Montgomery County. Yeah. So Laurel House goes into the schools. They actually their big event last year was on teen dating abuse, and they go into schools and do education within the school system. So I don't know if they have a similar summer program, but that's definitely something I can look into and let Christine know.
Also, Amanda would like to hear more about the connection to health issues down the line from ACEs.
From ACEs. Yeah, I mean, I think the important thing to recognize is the more ACEs you're exposed to, the higher risk of poor long-term health outcomes. And there are 10 different. The original studies show that are 10 different types of ACEs. And can't always remember all of them, but
we're
it's
gonna put it as a
exposure.
Facebook. We're gonna put it as an Instagram
Perfect.
slide,
Uh,
girl.
and and what's interesting about the ACE is I don't think it's full encompassing because it doesn't include racism and structural racism in there, which I think it was not included in the original study. So you add that on top of ACEs, a lot of our families experience. And a lot of times, these exposures can lead to, I'd mentioned mental health, and mental health can lead to poverty and food insecurity and experiencing homelessness. So those are a big piece. And so you'll often talk to people that have experienced homeless or poverty, and they've been exposed to abuse as well as ACEs as a child. I had mentioned the physical complaints. So we definitely see higher rates of cardiovascular disease, high blood pressure, poorly controlled diabetes, early death. Those, again, are, really all case mortality has been associated with increased exposure to more ACEs. And there's also resilience. Like, I think sometimes we look at multiple exposures, but then there's also, and I know, I wanted to change the language a little bit, that just because you're exposed to all these ACEs doesn't mean you're doomed. There is a resilience factor that is built into communities and families that really can change that trajectory for children. And I think that's something that's really important for us in healthcare. I remember when the ACEs studies came out, I don't know, 20 years ago, and it was very doom or gloom, like, oh, you have all these things, this is going to be bad. We've really tried to change that language in medicine. We don't screen for ACEs. We screen for resilience. And what does that mean is we ask about, well, what are you good at? What is going well in your life? Who in your family can you talk to? Because that is really, you could be exposed to all 10 ACEs. And if you have a resilient family or a personality or those support systems in place, you're going to be okay. And that's what's really important for us, is that sort of empowerment piece within medicine, because we do know that exposure can increase risk and harm down the road. So hopefully that expands it a little bit. There's a lot of good research out there. If you type into Google or Google Scholar, that will pretty much links ACEs to any sort of bad health outcome. I mean, I think other things in pediatrics is delayed immunizations, more emergency department visits, more hospitalizations, and so forth. So just to give you some more details.
Thank you so much. I love that you talked about resilience, because I feel like at Propose Project, we often say like we do with our clients a wins, like what's important now, because so much stuff is focused on like the trauma, but like what's important to you right now? How can we support you right now? How can we empower you? And I think that is a really good approach, because I think it's the things that happened in your past there's really like you had no control over, you know what I mean? But like what we do have control over is how we create
Yep.
community, how we cultivate, So thank you for sharing that. I love that so much.
You're welcome.
Erica, any other comments before we log off?
There are no other comments.
All right, so I just want to thank you all so much for listening in to our first Facebook Live of the season, and to remind you that we're doing this live in preparation for our 7th annual My Purple Path, which is an awareness walk / resource fair. We will be raising awareness about pediatric exposure to intimate partner violence. Tonight, we learned from the professional what it is, what's manifestations. At our walk, we are going to hear from survivors of pediatric exposure, share their stories, and share their hope as well. We're going to have vendors. There's still an opportunity to become a vendor if you're interested. We are looking for social service vendors as well as small business owners who would like to sell their product or service. We also have our t-shirts. Super excited. We haven't shown you all yet. We're going to do a release next week of our t-shirts for this year's Purple Path. But once again, we're really, really excited for Purple Path. It's going to be October the 5th from 12 to 4. Address is 800 McDade Boulevard in Collingdale, PA. It'll be a walk / resource fair. We will have components where we walk around the track 7 times because we know that studies show that it takes the average woman 7 times before she leaves an abusive relationship. So we walk around to honor the bravery and the sacrifice and everything it takes to get to that point. And then, like I said, we'll have performers, we'll have speakers, and we'll most importantly have resources as well to support eliminating barriers to care for folks. So thank you so much, Dr. Murray, for taking the time to be on our
Thank you.
platform. We really, really appreciate it. This was great knowledge, and looking forward to partnering with you in the future.
Thank you. And thank you for allowing me to join. And the amazing work you guys are doing is so impressive. So
Do you have
thank you
anything
again.
else you want to leave our audience with? Any upcoming events or any information you think is
Oh
necessary to share with
boy.
all?
I mean, I could talk, like I said, I could talk about this, this is what I do every day and I love it. And I, one of your attendees commented on they take assessment screens at their daughter's visit. And that's something that we're really trying to do more, with, more, what's the word? Consistent across the enterprise, because I think for a long time, pediatricians didn't feel that this was their job. And that was a culture shift that has slowly been taking place. And we're moving the needle, but it's something we still have to work at. And especially within large healthcare systems, how do we do it in a way that's trauma informed and healing centered? And that's really what my career goals are. So, yeah, thank you again.
No problem. Have a good night, everybody. I hope to see you all on October the 5th at noon at Collingdale Track. Have a good one.
Bye.